All right. So welcome, everyone. I'm so happy that you're joining us. Heather, please give yourself an introduction and tell us a little bit about your background.
Awesome. Well, my name's Heather Edwards. I've been a pelvic physical therapist for the past 16 years. And I'm also, as of the past, just this May, I officially completed my ASECT, which is the American Association of Sex Educators, Counselors, and Therapists. A mouthful. But the big certification process to become an ASECT certified sex counselor. And I did the University of Michigan program, which is a fantastic program to get the dual certificate in education and counseling. So I'm also a sex educator. Yeah, so that's kind of like as far as my professional stuff. My fun stuff is I have a group called Vino and Vulvas that is a local event series. And it's basically like sex ed in a bar. And we combine mental health professionals and medical professionals. And then we also tend to tie in like burlesque dancers and drag queens who have all sorts of different like street experience to kind of have this conversation together on a stage. And it's really fun.
So it's a live event. And where? Okay.
Yes. So I'm in Asheville, North Carolina, and it is a live event that we have every month. We've been doing this since 2015. It started off like just a few of us on like couches in a wine bar, and thinking like, who's going to want to come and listen to us talk, And now we have lots of people who want to come listen to us talk. So
love it.
Really fun.
And so people can find that on your website or where,
yes.
If someone was interested in joining.
Yes. So, and then we have another option too, because I know probably not very many of your viewers are necessarily local. So what I do is you can access the entire 2019 season, well, starting in April, which is when I started recording them. That was a really fun one called Beer and Buttholes, where, we brought everyone in talking about drag queens and anal sex, but then ended up talking about like, here's actually the best way to manage constipation. And here's how the internal and external sphincters work.
You've got to bring the pelvic floor back into it.
Right, exactly. So that was really fun. But yeah, so the whole season is available that you can get online as online event access. And that's like, it's a $35 fee to watch all of them from the year. Or there's ticketed fees if you're here for a live event. But vinoandvulvas.com.
Okay, vinoandvulvas.com.
And I think I have Vino and Vulvas. It's all spelled like that. But in the website, it's A&D in the website.
Mm-hmm. Awesome. That's fantastic. So there's remote options and there's on-site options.
Yes. Yeah. And in 2020, we're hoping to really like juice up the online options as far as the way that we can do more with that. This year, I was just like, I've got to do it. I've got to do something.
I know. Do you think you might do live participation? Is that possible? I don't really know how that would work, but
right. We'll have to see. There's lots of different options, and it all just depends on like what level of tech and how many computers I own.
I know. And then coordinating all of that and paying for all of that. So let's give you some support. So tell us about your coloring book too, please. And also, I know you offer some remote sessions as well. So give yourself some shout outs here.
Okay. So my coloring book, I have it somewhere here. So this is my coloring book. There's a whole story behind this. So it's Important Parts, a coloring book for the crotch enthusiast. I started this book because I was working with, lots of different reasons. A lot of the things that I do for Vino and Vulvas and also clinically, working with transgender and non-binary people, there is like all of our medical, if we think about like our pelvises, everyone's got a female
male or female
model.
Yeah.
Right. But then it's like if we can actually find a male model too,
true.
Holy cow, right?
Yeah.
And so then it's like, you're really doing good if you've got both.
Yeah.
Right. But then it's like, when we're talking about like the actual variation of pelvic anatomy, it's huge. Like there's far more than just two options. And then also for, the thing that I kind of realized with that is like, if you fall outside of that binary, it's sometimes really hard to talk about genitalia.
Kind of isolated and alone and bad.
Yeah, and especially if you have like a gender alignment that doesn't match what your genitals are. And then when you go and you see these binary things, right? Like it's, the female pelvis and the male pelvis. Well, female is, a gender largely, right? And it's separate from, our gender is separate from our genitalia. And but like that gets really hard because when people are born and they say it's a girl because it has a vagina, which actually isn't even true. It's a girl because it has a phallus that is less than a certain length.
Okay.
Right? And it's a boy is because it has a phallus that is more than a certain length. Right? So they don't even care if you have a vagina or not to call you a girl.
Interesting.
But, but then we learn girls have vaginas and boys have penises. And so all of those medical terms that we have become exceptionally like genderized.
Category.
Right?
Do you fall in this category or this category?
Right. So
and that's what binary means.
That's what binary means, exactly. That there are two categories and you have to check one box or another, right? So that if you are a man, like a transgender man, who the whole world sees as a man, and but you have a vulva and a vagina, like that can really kind of be challenging to talk about, and especially if you have any issues with it, like learning how to talk about it with your medical providers can be challenging, especially if you have to sit in a gynecologist's office with all these like pregnant women looking at you like, why are you here? Right. Mm-hmm. Yeah. So I created this coloring book as a so it's got all sorts of different options of crotches. And they're all like turned into fun, hilarious things like fiery stuff and guitars and hang on.
I love it. Are you going to show us?
Yeah. Like here's a fun like vulva that's, got snakes and trees. And then I think my very favorite one, I think it might be the first one. And this one, so, I call this one Goddess Cock. And so it's just kind of that like making a penis, right, more feminine for the women out there who have penises, and, and they may or may not want to call them that. This one is a fun one with big labia that extend past the outside one. So the dragonfly vulva. And
it's beautiful.
Yeah. Then like feminized versions of like a penis and scrotum where it looks more like a vulva. So
yeah, that took a lot of time.
Yeah, to think through like all the options and then like the options plus like the energy. Like, do I want to make them look more masculine or do I want to make them look more feminine?
And you did all the artwork yourself?
Yes.
You're talented.
Scrap paper and Sharpies is how this all started. Nice. It was kind of hilarious. Yeah.
So where can people purchase that? Also on your website, vinoandvulvas.com?
Yep. On my website. Right now, if anyone, it does happen to be in Asheville, a lot of the local booksellers have it. Malaprops and Baba Boom, which is a really great sex toy shop here in town. And lingerie, it's not just sex toys. I just like it most for the sex toys.
Okay.
Yeah, but then it's on Amazon. It's on indiebooks.org. But I mean, Amazon is the easiest to find it, and you can go through my website to get it there.
Good.
And I've got another one I'm hoping I can get out before Christmas. It has all the sagittal plane stuff and pelvic floor stuff. And so, yeah, so it is all, and I have all the different like labels in it so that, because that's another thing with talking through with medical professionals, right? Like if we only have the words of like vagina and vulva and penis, right? It's really tricky to have a trans person in your office who you're trying to discuss their concern, and the words that we're trying to use are super triggering of their dysphoria, right? But then like, so the idea is we'll use the words they like to use. But if they don't necessarily I mean, how many of us like rename our vulvas with, or our, penises with names that would be acceptable to use in a medical office, right?
Right.
I mean, usually if you're going to call your stuff something, it's usually something you would use with your intimate partner, which is not what you want to tell your doctor.
Yeah.
And so like just saying, oh, well, what do you call it can be kind of tricky too. So I, kind of create lots of different versions of how we can refer to our genitals still without using those terms. So like instead of like, vagina, using like canal if it's further up, or using introitus if it's at the opening, or instead of labia using like folds or, lateral folds, and instead of clitoris or penis using erectile tissue and, things like that. Yeah. So it's like you can still have a conversation and understand, and speak fluently with one another, but not get into words that are really hard for people to use with their body. Because, once you get like any sort of, trauma response with the patient, like you're kind of shut down. Like, and they don't,
that's it for that session. Yeah. And maybe that's it.
Yeah. That's it.
Yeah.
Right. And so, and I had an example of like this that happened, and like I did not have the words ready. And, and someone, they didn't have any words for what they wanted to use. And so it was just like, you know, like trying to get it from being like a staring match, but you know, like it was just, it was rough. And so I was like, never again.
Yeah. So this can be empowering for providers to understand some of the alternate terminology to use that's still accurately describing a medical
right.
Part of our body anatomy.
Right.
And then empowering for patients that aren't using those trigger words.
Yes, exactly. And for medical providers, the thing is like, they're words we already know. It's not like a newfangled terminology for anything. It's just like, oh, okay, we're going to use those words for this today. Yeah, like I didn't even think of that as an option usually, but it is. And it can still be really descriptive. So in all the drawings, like how I explain them and like, so, and I kind of suggest like, so here are like the parts of a vulva, right? So as you're going through and coloring these parts and you're looking at the anatomy that can have, you know, and like, so the non-gendered terms for it, as well as the gender terms to kind of understand all of those. But as you're looking through those and then you're coloring, you can be like, oh, here's where the, you know, the inner labia are, and here's where the outer labia, oh, and this is the vestibule, you know, and this is like this, and like, you know, so it's like all the landmarks to where if you went and you were trying to talk to someone about your body, like you would know the basic layout of your map, you know, and then you can even potentially draw it on a cocktail napkin if you need to.
Yeah, because I was at CSM and I think they were giving some examples of some art that you have, you know, and being able, like having us practice just building from the bottom.
That was me.
Was that you?
Yes.
Oh my goodness! So I've seen you. It was an amazing lecture. Amazing.
Thank you.
Yes.
Yeah.
Incredible.
That drawing lesson came from my coloring book.
Yes.
So like those were all the images from that. Mm-hmm.
Yeah. So really, really empowering. So as a provider, I'm going to deviate just a little bit from our questions, and we'll get through the questions that we can, and what we don't, we'll reschedule another one. So as a healthcare provider and somebody's coming in, how do you determine, and when do you determine if you're going to use non-gender terminology?
So if I have someone who, there are lots of layers of answers to that. Often, if I have a patient who is coming to me for a transgender pelvic related issue, I will have lots of heads up warnings from the doctor.
Intakes too?
Yeah, right. From intakes, but then usually it's going to be a doctor who knows that I do what I do, and they know that, like, okay, I'm going to send you to this pelvic physical therapist, because the transgender population does not have much reason to trust medical professionals. So usually if someone comes in to see you, they have like already heavily vetted you, talked to their friends, talked to their providers, made sure, and probably talked to you also, you know, just to make sure that they're not going to have an experience that really sucks, you know. And so often I will already kind of have established a little bit of rapport, even if that rapport is via someone, you know, like a medical provider or their therapist. Oh my gosh, when therapists get on board, like to help say, yes, I know her and she is really good.
They vouch for you.
Her. Yeah, that can be really helpful in actually getting someone in the door. But so then, like, if I have someone who I know that they're coming to me, say it is a transgender woman and she has a new vagina, I am absolutely going to use all the very gendered terms. It is a vulva, it is a vagina, all of that, because she just went through a big, huge journey to get a shiny new vulva. And so we are not going to even venture.
We're not calling it inner folds and outer folds.
No.
We want that vulva.
Right. And
so
the
labia minora.
Yes, exactly. So once that you have like realized what someone's gender align or gender like identity is, if their genitals that they have on their body then align with that gender, then like, you know, you can use that, right? And some people like just don't have any dysphoria around their genitals. So, you know, I've worked with transmasculine people who are like, no, like that's fine. It's my vulva and it's my vagina, you know, and we can talk through that and that's no problem. So in that case, like also fine, right? But like I kind of offer those, like you say, okay, so, you know, I'm a pelvic PT, you were referred here by a urologist, and I have like kind of this, I know basically what you're here for, you know, what sort of words feel comfortable? Here are the different options we can use. If it feels better to just use the traditional medical terms, we can do that. Or if you want me to use words that are still medical, but aren't necessarily like the gendered ones, I have options for that too. And I can show you and we can kind of use that language. I said, or like, if it would feel really affirming for you, like, you know, to refer to your, if it's like a transgender woman, like I can refer to your erectile tissue as your clitoris. And, you know, we can refer to, you know, like I'm totally fine with kind of doing the language swap on that too. That one's a little bit more tricky, but I think just even in offering that is like, oh, wow. Okay, cool.
And they care. They're accepting
and they
me.
care.
And they care.
Right.
And they're respecting me.
Mm-hmm. Right. And also kind of that level of like, I'm willing to make myself a little less comfortable in using terms that I don't use every day for these things in order to make you feel more comfortable. So it's that like, you know, because there's going to be discomfort in the room. And so then it comes down to the question of who's going to eat that discomfort, right? Am I going to push that discomfort on my patient to be able to manage and eat? Or am I going to be, and as my co-instructor for this course, Tuesday Farrell, who's an amazing human being, but Tuesday calls it it's like, it's your ally tax, right? It's eating the discomfort in the room so that the person, you know, who is in the differential with that power dynamic does not have to. Because as medical professionals, there's a very inherent power dynamic.
Yeah.
And so I think that also puts it on us to be the ones that eat the discomfort, you know, as opposed to putting forth any sort of
box and barriers.
Exactly.
Mm-hmm. Mm-hmm. That's beautiful. Okay, so I'm going to back up a little bit and just talk about terminology. So let's say someone that has zero or very limited interaction outside their circle. What does transgender mean? And what is trans feminine? What is trans masculine? What is, and trans man or trans woman? What, help us.
Yes, I can do that topic. Okay. So transgender, trans is a Latin prefix. Cis is also a Latin prefix, which means either same or different. Okay. So there's transgender and cisgender. So transgender means the gender that you were assigned at birth. And we use that word assigned at birth because, like I talked about with the anatomy, is not necessarily all that related to, I mean, it is related to your anatomy, but there's, you know, 1 in 100 people are,
yeah,
right.
There could be variances.
There could be variations, right? And in those cases, people are really assigned, or even babies are surgically assigned to one type of genitals or another, you know, which is another whole talk.
Yeah.
But so whichever gender you were assigned at birth, if that gender ends up feeling like the gender that you are, that you identify as, that your brain is, right? That you're like, yes, I see myself as a woman in this world and that feels right.
And I have a vagina.
And I have a vagina and I was assigned female at birth, then I am cisgender. Okay. If I was assigned female at birth because, you know, of a vagina or vulva, or my, you know, erectile tissue was shorter than what?
Was it 1 centimeter?
I didn't say what it was because I can't remember exactly what it is. Yeah.
But there's a cutoff.
There's a cutoff, right? And so if I was assigned female at birth, but really like you know, and maybe, and not everyone like realizes it when they're young. So I don't want to like make, you know, you think everyone, but you know, if you grow up being like, I'm going to be just like my dad when I grow up, I can't wait to have a beard, you know, like all of those things. And you really see yourself as like a boy or a man in the world, you know, and people kind of realize this later on in life too. I certainly realized a lot of kind of my like in between gender things, like, you know, in this past decade, you know, and it's like, and then it's like, you know, it all kind of like, oh, this makes a lot more sense of why this was always a really confusing thing for me. But so if you identify as differently than what you were assigned at birth, then you are transgender. Okay. So cisgender and transgender. Okay. Now, just to kind of layer on some terms we've already used with that, there's binary and non-binary.
So can we go back to transgender? I just want to restate that. So transgender, wait, no, you go ahead.
Okay. So transgender means that your inner sense of your identity of a gender of who you are in the world is different than what you were assigned at birth. Okay. So if I am a transgender woman, the woman part is the important part because I identify my gender as a woman. So a transgender woman might have a penis, or a transgender woman might have a new vagina, but we also are not making sure that we are equating any sort of genitals to what someone's gender is. Okay, but just to kind of clarify. So a transgender woman was assigned male at birth. Okay. And then a transgender man is someone who is assigned female at birth.
But they're identifying, which is the trans. right?
The trans, right? Trans,
not
man.
the cis.
Right, right, yeah. And the reason we use cisgender is so that we don't just have normative language. Like if I say, you know, women, ideally women should mean anyone who identifies as a woman, right? But right now it doesn't. So if I say cisgender women and transgender women are all welcome in this space, then that is inclusive. And it doesn't, it tells you that I am not using the default of saying women, but really meaning cisgender women and making it not safe for transgender women. If that makes sense.
It makes beautiful sense. And I thank you for breaking it down so beautifully.
Yeah. Okay. And so then the terms you asked about, transmasculine and transfeminine. So those basically, that starts to get kind of into non-binary stuff, but those are more like directional words. So if someone was assigned male at birth, but then they identify as anything other than a cisgender man, then they are generally going to be trans feminine, because they, whatever their gender is, it's transitioning in a way
away from
feminine. Right. So they might identify as a transgender woman, they might identify as non-binary, but it's a trans feminine direction. Okay.
And then binary,
yes, I will get there in just a second. Right. So then it's the same thing, right? So if someone is trans masculine, then that would be someone like myself, who I don't really necessarily identify as just like a cisgender woman. And so like I identify a little more non-binary. So I would be like considered a trans-masculine non-binary person, right? I understand that like the world very much looks at me like a cisgender woman, and I occupy a lot of cisgender female privilege, which means that people aren't going to look at me and be like, oh, she's one of those, right? You know, so that...
Or why she's sitting in the OBGYN waiting room.
Right, exactly. I'm not going to have to deal with any of that based on my appearance, right? But if you're just looking at like, you know, kind of where, if I'm considering myself a little more non-binary, it's in a trans-masculine direction.
Good.
Okay? So, and then so binary and non-binary is what we're going back to, right?
Yep.
Okay.
Yep.
So binary, so transgender people can still be binary. Okay, so it's kind of a different sort. It's like we've got
another category:
male, female, binary, non-binary. You know, as far as kind of how we're layering it. So a cisgender woman or a cisgender person at all can be very like, that's usually binary, right? Because they either identify as female or male. Okay, and so for transgender people, someone might have been like assigned female at birth, but identify as a man, as a trans man. But they don't identify anywhere in the middle. They identify as a man in the world. So they want to go, they're going from, you know, check the F box to check the M box, right? But they are still going with the system that is those two boxes, all right? So non-binary means you either identify both boxes at the same time, or you really don't care about the boxes and you identify somewhere around here. So,
other.
That makes sense? Other.
Yeah.
Right. Yeah.
And there can be a wide variation there. It's not just one box for other.
Oh, right. Yeah. No. That's a huge variation.
Good. Very helpful. Okay. Surgery versus non-surgery. So what percentage of people would you say that identify as trans have surgical procedures to equip them for that definition, I guess?
I so wish I had those slides pulled up right now.
I know. I kind of think it was less than 10% or something. That was in my mind.
Right.
Maybe 5%.
Yes.
It was
so I think I can remember pretty well. So these are the numbers that came from the 2015 U.S. Trans Survey. So it was a really big survey that came out. So often people will think of transgender people as someone that has transitioned after they have had the surgery to change their genitals, which is completely not true. Someone can be transgender and have take no hormones, take no surgery. That's how they identify, you know, but they're not going to, they don't want to alter their body for a multiple, you know, either because they
whatever
just don't
reason.
Want to, right, or because they can't afford it, or because, like, for whatever reason, that does not make them less transgender than someone who has gone through and done hormonal or surgical transitioning. So I really want to make sure that everyone understands that, right? Like, we do not negate any trans identities based on their surgical status or their hormone status.
Right. That it's not like they're only real if they had surgery. They're real because maybe real is an awful word, but
the transition isn't just a surgical transition. I mean, the transition starts when you just Right. You realize it, and then like you tell someone about it, and then maybe you change your pronouns, or maybe you change your name, or maybe, you know, I mean, there's so many levels to transitioning, and it usually starts with a little bit of kind of social transitioning, maybe a little bit of hormonal transitioning for some, like, you know, but it's a big, huge process. It's not like a magic wand was waved on you and now you have transitioned, right? So it can look like that when we see things like Caitlyn Jenner, right? You know, like all of a sudden, you know, but
Bam.
she has a lot of resources.
Yeah.
Let's see. So as far as the surgical transition, the vaginoplasty, which is creating a new vagina and vulva for someone who is assigned male at birth, it's generally about like 10% of people have had that surgery. But there's always like a significant percent that don't even want, you know, the surgeries. But about 10% have had that surgery. And that's a pretty big percentage, you know, when you look at all the barriers that are like kind of working
and access,
and access, right? That surgery has, it's done a lot more often, and so I think the procedure is a little bit better. There's a better success rate for it. You know, there's more, like even just in the past few years, the amount of surgeons in the U.S. that are doing it, there's a lot more, because before everyone was going to Thailand to go and have a major surgery, stay there for a few weeks, and then fly all the way back sitting on their new genitals.
And then what's the follow-up?
And then there is none.
Yeah, because you have to fly back to Thailand.
Right. And they don't. And so then there's no one in the U.S. that'll work with them. This was one of the things that made me want to start working with this population, was that when I realized what was going on, and I'm like, oh my gosh, like I've seen people with like ridiculous complications just after like a hysterectomy or a bladder sling or something like that. Like I can't imagine like completely rechanging or, restructuring your genitals and then being like, oh, no medical care, So, right. So that was kind of my big surge into bringing this into public PT, because I'm like, oh my gosh, we should be leading this team, because like, this is our thing, you know?
This is our area of the body.
Right. And, and so as far as phalloplasty, I think it's like less, like maybe 2%, like 1 or 2% of trans masculine individuals have actually had a phalloplasty.
And that is creating penile and erectile tissue.
Yes. Well, it's not going to be erectile. Right. Yeah, it usually comes, it's a graft, a full thickness graft that comes from the forearm or the thigh. And so there has to be an erect, and, what are they called? I'm totally blanking out. The prosthesis, penile prosthesis goes in to create any sort of erection, because it's not erectile.
And then it might have a pump or it might not.
Right. Yeah. So there's several different kinds. There's the malleable ones, which you can just kind of bend. It's the same ones that we would use for someone with erectile dysfunction who's a cisgender male. Good. So, but yeah, so it could be any of those. And again, people may or may not want that, But yeah, so only like 1 to 2% of people, of trans masculine people, have that surgery done. So again, when we're thinking of trans people and like, what are their needs, the most often the questions come, through the public PT pipelines, when they're like, oh my gosh, there's a surgeon in our area who's now doing these surgeries, and I'm going to start seeing trans people now. But really what that means is like, you're seeing like the teeny tiny percentage of trans people who
that have
the ability to have surgery and have access to care and have access to physical therapy, when the vast majority of trans people do not have those things. And with the phalloplasties, I think it was something, I don't remember, but it's like over 50% of trans men do not want a phalloplasty. What is far more common for trans women and trans men is to just get top surgery. And you can think of that for trans men, right? Like if you're just trying to get through the world without being harassed and look like a cisgender man, like getting rid of your boobs can be important, right? Mm-hmm. Growing a beard can be important. So some of, those things are, though, sometimes I saw this documentary and someone was laughing about how even though they had very large boobs, because they had a beard, like that trumped it. So like it wasn't even, like no one even noticed their boobs because of the beard. So it's funny, like all those little ways that we look and
categorize people.
That we categorize people, which we do all the time.
So this is a good segue into implicit bias. So what does that mean, and what does that look like?
Right. So implicit bias is something that we absolutely all have. Like if you feel as if you are free of implicit bias, like it's not possible, because we've got these amazing brains that really like to connect dots and put things into categories. And so, the way the experiences of our life, the way we were raised, the way everyone around us talks about the world, it affects how we see it. If you come from a family who was, very racist, and always had like a way of speaking about, Black people or Mexicans or anything like that was super negative, you're likely that there's going to be, even if you completely disagree with it, there's going to be like that little bit of like, it's going to be harder to be able to like not have to do an intellectual reroute to figure out, oh, that's that thing that I'm thinking because of these things, and I really have to examine that and to move forward on that, right? So it's if we just say that we don't have implicit bias, it's like saying we don't see color and we don't see. I don't judge people. I don't even notice what your gender is. Like, you do. Like your brain is doing that. If you're just saying that you don't, like if you see someone who looks androgynous, like what are the things you look for, right? Like
we're looking at hair, face, right, breasts, how they dress.
Is there an Adam's apple, right? Is there like, how are they presenting themselves? Like, there's all sorts of things. And it's not a bad judgmental thing. It's like, we're trying to understand so that we can be correct with what we're saying, like if we're using she or he pronouns for someone, this fantastic gendered pronoun thing is, that's
a whole nother interview too.
Right. There's a lot of them. But yeah, so our brains just are automatically making all these connections. And, and I just use examples of like gender and race, but it's about everything, yeah, right? I mean, it applies to everything. And so the more that we can understand what those biases are and be able to check ourselves on it, the better, So when we have those like knee-jerk reactions, be like, oh, wait, I feel that just happened. Yeah. And what was it that made that happen? And is that an actual reason? Like, should I actually feel unsafe in this situation? Or is this just based on a past experience, but really this situation is not unsafe? And so understanding, because often like, as a white, seemingly cisgender woman of middle class, like I occupy so much privilege, right? And so this is the thing, with white women calling the cops on anyone that looks remotely suspicious, right? It's that doing that knee-jerk reaction, something doesn't look right, so I need someone to come investigate it, instead of actually understanding that, like, I'm actually not in any sort of danger here. There's nothing scary about this. So just because I had some sort of weird little warning sign goes off, I actually need to check what that warning sign
Why did that happen?
As opposed to acting on it, right? And so I can't remember what it is. There's a really cool website it's like research that a university, I think, is doing. Yes. Have you seen this? It's the implicit bias test. And it's really cool, because what you do is you go through lots of different things, but there's one where you look at like humans who are Black and humans that are white, and there's words that come up, and some of them are positive words and some of them are bad words, and you
and you have to respond very quickly.
Like it's right.
Just your, and then it categorizes you.
Exactly. So it's like, oh, you had a really easy time saying that, the positive words with anyone who is white, but it took you like
there was a delay
to do that when you were supposed to put positive words with Black faces, and so it goes through and does a lot of that, and that's what it is. And so like, and those are things that like, if they can and will come up for everyone, but if we just have like, oh, well, that's just how I was raised, or that's just my experience, like that's really dangerous.
Yeah, because you're just like, you're not open to evolving.
You're not open to right, and you're making the world much less safe for people who do not occupy your same privilege. Yep. So that's good. Yeah, and as medical providers, like that's really important, because these people are sitting in front of us. And so whatever our implicit bias is about them is going to change the way we phrase things, is going to change the way, and people are noticing this, right? Like they're listening to all these keywords and phrases and delays and how you talk about things to decide whether or not you are actually safe, whether or not they can actually give you their true medical history, on what's going on, and if they're ever going to come see you again, you're in an interview process that whole first time you're treating someone.
Regardless of who it is, every single person you are.
Right.
So let's go into some of the issues that the trans community faces. I know this is like a whole huge interview, but I remember some key things from CSM, like the suicide rates, the depression rates, the access to medical care. Like it's huge issues.
Huge issues. Yeah. I mean, you know, like, I just think of the examples of like when I started becoming awake to like what was going on. And then I'm like, well, but I'm not seeing any trans patients.
Where are they?
Where are they? Yeah. And there's no discussion of it. Like I'm in all of these like Facebook groups and things with people all over the world talking about, you know, public health groups. No one's talking about anything related to trans stuff, you know, and then it's because of all of these other factors as why. So, you know, as far as including, you know, creating inclusive care, if we are just saying that, oh, I treat everyone equally, they can come in and see me and I'll just do my best. And, you know, like that doesn't cut it. Like that's actually like the opposite of helpful, you know, like you actually have to go out and learn. Intentionally this stuff. Right. But yeah, so as far as like and Tuesday and I refer to this part as the depressing stats part of the talk, right? And this comes from the 2015 U.S. Trans Survey too. There's a new one that should be coming out here this year, but yeah, just kind of using these numbers that are pretty good. It's like greater than 50% of trans people have attempted suicide at some point in their lives. You know, and like a ridiculous high percentage, like have had, you know, significant mental distress in the past year. You know, they can get fired from their jobs, they can lose their housing, you know, all of these things.
Family reactions, they might get kicked out.
Family reactions, right, just based on their gender or how they present themselves in the world. So that's another thing to keep in mind too, as we're looking at our current political our political stuff. Like it's in the Supreme Court right now of if that's okay. Like, can gay people and trans people be fired from their jobs because of them being gay or trans? You know, like that's being argued right now as if that is something that, like, you know, and that's why it's dehumanizing, right? Like it's saying because of who I love or because of my gender, that means that I should not have access to, you know, to a job, to housing. And
safety.
What that tries to do, right, it just tries to erase those people from public life, right? So it just says that, like, yeah, we
want you to be invisible. We don't want to see you.
Right.
So we want to pretend like you don't exist.
And so we need you to either pretend like you don't exist and fall in line, which is what's happened for decades, right?
Because they needed access and they needed a job and
and housing. Yeah.
And housing.
Yeah, so all of those super basic levels. So you can see with, like, when those are the things that are problematic, like getting in to see pelvic physical therapy, like that is such a tip top of the, you know, of the pyramid of needs. Of by the time someone can actually get in to see pelvic PT, they've got to have so many other things going for them already.
Yeah.
You know? So, let's see. And another really important thing to note with this is when those same numbers, like the depressing stats, and that also includes like addiction and, you know, all of those things that come from like a high ACEs score, like the high childhood trauma stuff, the how society views you, that constant pressure, the microaggressions every day from just like trying to live your life and have people, you know, say slurs at you or like intentionally use the wrong pronouns, you know. So things like that, like those all just build up so much. But one of the things that can really significantly decrease the suicide scores is family support. Okay. It drops it down to the same amount as the rest of the population.
Somebody has your back.
Yep.
This is my safe place.
Right. And so that's just like such an important part for people to understand, especially, you know, any sort of parents who are like, oh my gosh, my child's trans. I just don't want them to have to go through life like this. You know, all of those things that are really great parental concerns, like those are actually dramatically increasing your kid's risk of killing themselves, you know? Right. And so, and
love them, accept them.
Right.
Be like, there.
Get yourself to like, if you love your child and you don't want these depressing stats to be the ones that happen for you, it's not by trying to make them hide. It's not by trying to make them not transgender that you're going to keep them from the things that are challenging for the trans population. It's by getting yourself to a place to where you can absolutely, you might not have to understand it all, but you've got to love and support and be there for them and have their back and learn so much, like listen to other trans people of understanding what's going on, because just trying to ignore it and say like, you know, oh, like this isn't true, like I don't believe in this stuff, or, you know, like, yeah, that's not helping.
So your live event that you have recorded for 2019, that might be a great start even for people to listen to and to become familiar even with terminology, right?
Right. Yeah, so definitely the terminology. We have, and I try to, on all the panels, many of the panels have trans people on them, but we are trans inclusive in everything we do. We're not heteronormative, which means like assuming if we're talking about sex that we're talking about a man and a woman and penis and vagina intercourse, right? Which is often what happens when there's any sort of sex talks that are happening, right? And so we try to avoid that entire narrative where anything is normative as we're going through and doing these discussions. So even just like starting to understand that as you're listening to these talks, it's like, oh yeah, like these really apply to everyone and anyone, and really we all have far more things that are similar. Because even just looking at like cisgender women, right? Like when the narrative for heterosexual sex is such that it's like, okay, well, women generally don't want to have sex and their husbands want to have sex all the time, and you know, maybe it's painful for them, or like, you know, there's a narrative that we've got and it's super strong in pelvic PT, right? Well, like what happens when it's like, no, actually the woman actually has a really high libido and wants to have, like, you know, there's like that woman is kind of made to feel like a freak, you know? And not necessarily, but like it's much harder to find a normative narrative that involves a woman who really wants to have sex and a husband who does not want to have sex.
Even I need to do better. I need to do better.
But yeah, but it's just, it's all those things where like we apply this narrative and like, and people can tell, like, you know, if I'm having a conversation with a medical provider and like I can see the narrative they're putting on me, I'm like, oh, we need to back up because you don't understand this about me. But most people will not do that, right? Yeah. Most people will just understand, oh, she doesn't get it, and this is going to take far more energy than I have it worth.
Most people are not going to confront the situation, whatever it is. Just exit.
Right. Mm-hmm. Yeah. So just, and so I really like to kind of, like when I do trainings for public PTs, is really suggest like, don't apply, and like people only have to come out to you when you have assumed a narrative on them, right? Does that make sense?
So, right. Well, please elaborate.
Yeah. I was going to say, because coming out means that like I have to go against your assumption of me and actually say, oh no, I'm actually this instead, right? So if you don't ever apply a narrative to me,
then I don't have to do that.
Out. I can just tell you the truth of who I am. And there's never a time where I have to like be like, okay, is it okay for me to actually tell her that I would rather have that I have sex with women and not men? Like, is she someone who can handle that, or am I going to get judgy face? Mm-hmm. You know, right? Because if you've said something like, oh, so you know, are you sexually active, and you know, how are things between you and your husband?
Yeah.
Then
do you like does the penis hurt when it's inserted, or what? Yeah.
Right. Mm-hmm. Yeah. But so now I'm in a situation to where you've made an assumption and I need to come out.
Yeah.
Right. And I have to decide whether or not I want to. And also like whether or not you're actually competent to talk about the kind of sex that girls might have that is different than how, mm-hmm. you know, boys and girls would have sex together. Like, I'm like, does she know anything about that? Or is she just going to get really big eyes and like,
red and then leave the room?
Yep.
That's
not
beautiful.
Fun.
No. So you do pelvic PT trainings as well. So would if a therapist or even a non-pelvic therapist wanted to go to a class, is that on your website, or where could they find where you're teaching?
So actually the courses that I'm teaching right now are all on Pelvic Guru Academy. So at pelvicguru.com/courses.
With Tracy.
Yeah, Tracy's. Yeah. And so, or you can just click the courses button and it'll take you right there. I've got one coming up in January so I've been teaching the past 3 courses I taught for Pelvic Guru were all like trans specific courses. And it was fun. And I taught with my co-instructor Tuesday, who's like I said, just one of my I swear, like I probably just agreed to do these courses because I knew that Tuesday and I would get to spend 4 days together. And it's
you get
totally
to have dinner,
like it has worked that
lunch.
way. Oh, right. And share a hotel and like, it's just been so much fun. But yeah, so I've been teaching courses that are more specifically trans courses. And so the one that I'm going to do in January is going to be a little different, where it's going to be actually focused more on like the sex counseling piece.
Okay.
And so taking all of these challenging things that any of our patients come into us with, you know, like, oh, well, my libido or this, or, you know, like this thing's going on with my head, like just all of those things that like, we're like, oh, well, let's see how your pelvic floor muscles are, you know, like there's a lot more to it than that. Yeah. So I want to go through and give people like really good skills on how to be able to facilitate like that erotic intelligence and that like sense of someone's sexual self, and not just tying it to whether or not your vagina hurts.
Good. So that's another interview that we're going to schedule.
Okay. So many. But yeah, so but within that course is also going to be trans inclusive, which means that there's not like, we're going to make sure that that is part of the experiences that are normative for everyone else, or, you know, that we talk about. So, and it's also going to be trauma informed. So we'll be doing a lot of talk with how to deal with trauma triggers in your patients and with yourselves, because that happens a lot, right? When we're sitting there, you know, teaching with a or a mental health professional, it's one of the things that's been really interesting for me to kind of like put together and process is like, I've realized that as medical professionals, we seem to be trained to think that we are actually like objective bystanders in a room when we're treating someone, right?
Yeah.
Which is hilarious.
Because, you know, we bring everything with us.
Everything. And so mental health professionals are trained very clearly that, look, every time you're in a room with a client, like you have all of your baggage, everything about who you are is in there with you. And so you need to deal with that stuff, you know? And so that's a kind of part of what we start doing with this course, is like starting to understand, like, this is not just about like learning a manual technique and, you know, some stretches and some things. Like, it's about like examining who you are and what your reactions are and where your strengths are.
How you phrase your questions.
How you phrase your questions, how you react, like what is that inner, like when you are faced with a challenge or something that seems like it is like someone is kind of coming at you, you know, because that happens in treatment rooms too, right? Like what is your response to it, you know, so it's not like just dragging us through the mud, but we can be like, oh, I'm doing that thing.
Yeah.
Okay,
being able to identify and have a solution.
Exactly. And so that you can still make what you're doing effective. So we'll be talking through a lot of the trauma stuff, but then it's also a kink informed or kink aware class. And so we'll also be talking about like all the different stuff that goes along with like kink and BDSM, and how actually like BDSM and kink structure can be super helpful medically, because it is such a very clear communication.
This is my boundary.
Right. This is my boundary.
This is what I want.
This is how we set something up. Right. Communicating before, during, and after sex. Like, you know, it's like the work's been done for us. We just don't see it, and we look at it as like other and scary, right? But when we look at like the structure of what people who are doing some of the scarier stuff have set up, because when you're doing some of the stuff that has a higher risk involved, like, you really need good rules and good communication. Well, guess what? When we've got someone who's got like vaginal pain, right, or scrotal pain or whatever that happens during sex, like all of a sudden that becomes a pretty risky activity, right? And so it's really good to have all of those same structures in place.
This is what I say, or this is, okay.
Right, yeah, like understand all that. So so it'll be all of that, and then we'll still be some stuff that is like the second day we'll have things that are more trans specific, just because that is a lacking area of knowledge, to kind of like bring that up a little bit too with it. But so it'll be largely sex counseling with a heavy chunk of trans.
All right. So pelvicguru.com and look at education, and then scroll down.
Courses.
Courses.
It's under courses, right? And it's the very first one coming up because it's January in San Diego, and I believe it's the 18th and 19th.
Okay.
It's not the exact weekend. It's that weekend.
That's awesome.
Yeah.
So we're nearing the end of our time here. And is there anything that you would like to communicate to anybody that might be watching, whether it be a healthcare provider, whether it be a friend, whether it be someone that's having feelings that they're really not sure what to do with?
Right.
Okay, that was a whole wide range. I know.
Right.
What do you want to say?
I would say that often the topics that I talk about come across as things that like people have really not ever considered or thought about. And so people can often just from like hearing this conversation even maybe be kind of feeling like, oh, like, did she just call me out on something? Or is this something I like, oh, you know, or like the stuff about like, you know, how to raise your kid if your kid is trans, you know, well, you know, there's all sorts of stuff that I just said within this interview that could have been like, whoa, okay. Yeah. So what I would encourage you that if anything did hit you like that, like follow that, journal about it a little bit, write about it, like research a little bit more about it, and just kind of see, I mean, you know, you don't have to agree with me obviously, but like I'm trying to be here to kind of like help make the world better for everyone.
Increase awareness.
Yeah. So so if anything hit you as like made you flinch a little bit, like follow that, pay attention to it. Don't just ignore it and say, oh, well, I'm going to go listen to someone who talks about it differently.
Yeah, I feel more comfortable with this, so I'm going to go over there. Right. Yeah. The fact that you're feeling uncomfortable or like, oh, I need to do better, then you might need to do better and really analyze what's happening.
Yeah. And like, and I have those moments all the time, right? Like something will happen and I'll be like, oh, you know, like, what was that? Like,
okay, good. That's good to hear because you're like the expert. And so if you're still experiencing that, there's hope for the rest of us.
Always learning. Oh my gosh. I just did, like one of the last VMB ones was surprisingly challenging for me. It was a talk about masculinity. And like, I just felt myself just like, I don't want to do, like, why did I schedule this? Like, I don't want to do this. And it was like, there were so many things. And of course, then I started my period on that day too. So like, it was really fun and emotionally challenging to like sit up there and talk about patriarchy and everything. I'm like, ugh. But you know, I did it. Like I did my research. I felt it out. Like I learned so much about myself and, you know, and all of that just from being able to own that, like, this is really a hard topic for me to talk about, you know, and, you know, masculinity, that doesn't seem like it should be that challenging, but it was like, it really pushed me.
Yep.
So, and there's been lots of them like that I've done. So
I think as therapists, you know, we're just growing and people hopefully, but you want to help your patients. And so that's often, I think, the trigger to go and learn more, you know, so.
Right. And right. And you can't see what you don't see. Right.
Right.
Like, so just because you're like, oh, well, none of my patients are ever transgender. You might be having like a transgender, you know, man who comes in to see you all the time. But when he comes in to see you, he puts on girl clothes. He dresses in drag, you know, so that he can just go through and do this like super annoying thing of pretending like he's a woman. So it's not weird for you to work on him, on his vulva. You know,
you might not be the safe person.
Exactly. Yep. And so, yeah, so just kind of being like, oh, I don't, like, this doesn't apply to me. Like, it does.
It does. Good. Well, thank you so much. This is going to be recorded, and we'll put it up on our YouTube channel, My Pelvic Floor Muscles, no spaces. Check out your website, vinoandvulvas.com.
Yes.
And stay tuned for another interview, probably sometime in 2020. So thank you so much, Heather. I really appreciate your time.
It was fun. I appreciate what you do, and this was super fun to do. And now I understand how to do Instagram.
I know. Yay! You got it. You got it. Thank you, everybody, for joining us. Have a great day, and take care.
Thank you.
Bye-bye.
Bye.